Hello to everyone. My name is Rose Gerber. I'm the Director of Patient Advocacy and Education for the Community Oncology Alliance. I'm so happy that you can be with us this month. It is National Pharmacist Month. And as you know, through these advocacy chats, which we've been now doing for 5 years, we bring you very topical information. We try to shine the light on a lot of the initiatives that we work with COA. We also like to show you members of the community oncology staff. And whenever possible, we try to tie that into something that is happening during that month. And this month, we have the best of both worlds. It is National Pharmacist Month. And my guest today is my colleague, Christine Pfaff, and I hope I got her last name correct. She is not new to the community oncology space, but she is brand new to COA, and so we're very happy to have her as part of the team. Real quick, I do know that I'm connected with so many of you on LinkedIn, and if we're not, please reach out and we can be connected on LinkedIn where I share advocacy news and opportunities. And when I was sharing this particular promotion for this month's advocacy chat, what I wrote was that when a patient is diagnosed, and everybody that has been a patient or knows a patient or has been a caregiver knows that fear and anxiety when you're newly diagnosed. It can be immobilizing. You can feel so despondent, but kind of what gets you out of that despair almost is when you start treatment, because then your doctor has a plan, you're going to do your part, they're going to do their part, so then you start to exhale. Now, unfortunately, what's been happening more and more often, and we love to talk about COA because it's a big issue, is that pharmacy benefit managers, PBMs as we refer to them, are continually and increasingly getting in between the oncologist and the patient. And that's super annoying because several of our doctors have said they didn't go to medical school, so why are they trying to be involved in this clinical decisions? But what really the impact on patients is really it causes delays in treatment, and that is more anxiety producing. So today we're going to hear the perspective of a pharmacist. Again, Christine is a very talented woman and colleague, and she's going to share her knowledge with us today. Thank you, Christine, and welcome.
Thanks, Rose. Thanks for the great welcome, and I'm very excited and happy to be here with all of you today. I'm speaking about PBMs, or pharmacy benefit managers, and educating you on that, and more importantly, what you can do and what we can do together to help get patients the medications that they need and deserve in a timely fashion. And so I'll just introduce myself a little bit. Christine's my name, and a pharmacist. So I went to Ohio State University for my pharmacy degree many years ago, and I had the pleasure of practicing in a community oncology practice here in Columbus, Ohio, at the Zangmeister Cancer Center, and spent the majority of my career, 20 years, in a pharmacy helping patients and giving them the medications that their doctors prescribed. In our clinic, we had a great team. We had nurses, pharmacists, a wonderful social worker, nurse practitioners, and physician assistants. And my area was the pharmacy, and we really had a great team that would help work with our patients and their caregivers to get them their medication. And so one of the barriers that we found, which honestly I had no idea even existed, was pharmacy benefit managers. And so next slide, please. So what is a PBM, or pharmacy benefit manager? They are the middleman between insurance manufacturers who make the medication and pharmacies like where I worked, and patients and patient advocates like all of you. They help design and manage formularies. And so a formulary is a list of drugs that an insurance company will cover. So some insurance companies restrict the types of medication that they cover for different reasons, and pharmacy benefit managers help them come up with that list. They also process and pay prescription drug claims. And that was one of the original reasons for a pharmacy benefits manager, was to help insurance companies pay for prescriptions. Very simple reason to exist. And it's kind of changed into something different today. Another interesting thing about PBMs is that some of them own and operate their own mail order pharmacy or a specialty pharmacy. And I'll share a little bit later a story about one of my patients who had a situation like this. And they also negotiate drug prices and rebates with manufacturers. So if you think about your physician's office and the pharmacy that's in the physician's office or that's associated with it, then there's this kind of middleman in between, and then there's the insurance company, and it's a very complicated relationship. And I'm going to try and help you understand what that looks like and talk about ways that we can help patients get their medications. So next slide, please. So who are the top 3 PBMs in the United States? And this is not a trick question. It's there are 3, CVS Caremark, Cigna, who has Express Scripts, and United Health Group, who has Optum Rx. And they own over 75% of the PBM business. So really, the vast majority of PBM business goes through these 3. And if you look over to the right at that chart, that's kind of confusing. You'll see that at the top is the insurance company. So for example, we have United Healthcare. My insurance is United Healthcare. My insurance company also owns a PBM that also owns a specialty pharmacy. And in some cases, they also have physicians that work for them. So I think it's important to understand that a lot of these PBMs are owned by an insurance company. So thinking that, they all are kind of working together to see their best interests at heart. So next slide, please. So very important here, how do PBMs impact cancer patient care? Well, initially PBMs were intended to lower costs. And as I mentioned a little bit earlier, they kind of helped us process prescriptions. So, when you walked up to the pharmacy, you knew how much your insurance was going to charge. They have now changed into something that unfortunately impacts cancer patients in a negative way. They create delays in cancer care. And some examples of that would be prior authorization and requesting information from the physician about why they're giving a medication. Sometimes they want more information from the physician or the nurse, and that can cause a delay in care. They also can restrict access to medication. So we spoke about earlier a formulary. So if the drug the prescriber wants you to have, so if your doctor wants you to have a medicine and it's not on formulary, then you may not be able to get access to it easily. And so sometimes that can be a problem where they're restricting certain medications for patients. Additionally, it can drive up patient costs because they're adding on extra fees kind of in that middle spot that we spoke about. We're not exactly sure what the cost goes towards, but it definitely drives up patient costs. And when we're talking about our cancer patients, access to care, in my opinion, quickly is very important. You want to know that you're treating your cancer with whatever the physician thinks is best based on their knowledge and all of the years they went to school. And you want to be able to access it quickly and easily and safely at an affordable cost. And PBMs negatively impact all of those needs as a patient.
Christine, I have a question. The first
Sure.
one creates delays in cancer care. Something that I believe that we've heard over the years is that even though there's all these prior auth and different requirements, at the end, the drug will eventually be approved. Or do we know what the percentages are on that? So basically, the patient got delayed, which is super anxiety producing, frustrating, but then they're going to approve it anyway. So can you give us some insight on that, please?
Absolutely, yes. So I don't know the number or have a percentage for you, Rose, but I can share that in the practice that I worked at, there was never a situation where the drug was not approved, and meaning that yes, the patients are getting that medicine. Now, it might be a week, it might be 2 weeks, it might be a month, sometimes 3 months later. And our staff, so the pharmacy staff, the pharmacists and the technicians, were calling the insurance company, calling the PBM, working very hard to get the medicine for the patient. and knowing that that time clock keeps ticking. And we're feeling that anxiety too, because we really want our patients to get what they need. I mean, that's our whole job. Why would I be an oncology pharmacist if I didn't want to give patients the medicine they need? So that causes a lot of anxiety for patients, for their family, and for the providers, for the physicians and the practice staff. And sometimes it, like I said, I had some situations where, a couple of days is, I would say, normal. 1 week, one even up to 2 weeks would be, I would say, a normal turnaround time. Um, but 2, 3, 4 weeks, multiple requests for more information, um, really causing a lot of delay in cancer care unnecessarily because the patient's getting what the physician wrote for to begin with. And
Thank
so
you.
those middlemen are stepping in and kind of disrupting that care that the patient needs. Definitely can be very stressful for everyone involved. So, next slide. Okay, so if your coffee shop was set up like a PBM, I'm not going to play the video for you today. And if you have been involved in COA and CPAN in the past, you probably have seen this video. But I still keep going back to it, 10 years later, because it explains it in terms that I understand. And, I live this. I've worked in an oncology pharmacy for so long, and it's still not easy to understand even for me. So I love that this compares it to a coffee shop. And if you'll move to the next slide, please. Thank you. If you click on the link, that'll take you to the YouTube video, which you can watch. It's only like 2 or 3 minutes. And it explains it better than I'm going to right now with these pictures. But I always think when I go to the coffee shop, I am asking for the cup of coffee, and I, say it's $5. I've got my $5, and I give them my money, and they give me the coffee, and I walk away, and I'm happily caffeinated. And
Like that.
and it's simple. I mean, and behind the scenes, the coffee manufacturers roasting the beans and doing all those things. But when I'm paying that $5, I'm paying for the coffee and for the service of the coffee place, the Starbucks or wherever I'm going for the day. My local coffee shop's my favorite. Um, so if your coffee shop was set up like a PBM, I would be paying the coffee shop, and there would be all of this confusing, and I'm using my hands here to explain. There's confusing in between steps that are happening. So you've got the insurance company, you've got the pharmacy benefit manager, you've got the manufacturer, the bean roaster who's like making the pills, all working together to get this medicine to the patient. But all along there, they're adding in a little extra cost. So the PBM saying, I want my little piece of this, and the insurance company wants their little piece. And so rather than just simply getting your cup of coffee, you are paying for all these extra people to be involved. And it's very complicated. And simply making it simple with coffee is a little bit cute and funny, but it does help explain how cumbersome the process is, Rose. Um, if you'll move to the next slide, please. So this is a very confusing graph of where all of this happens. And the point of this is that as someone who's worked in an oncology pharmacy, I don't get confused in understanding how this works. So it's really, really hard for patients and for patient advocates and for everyone involved to understand what's going on. So I wanted to share this because I'm not going to explain it, but I'm going to share that in the bottom left corner is the patient, which they really should be in the center. The patient needs to be in the center. And I think we're getting push and pull from all these different other organizations that are around the outside of the screen. And I want to know how they're helping patients. And I think when we talk about pharmacy benefit managers, we're not seeing a lot of help for our patients. Rose, does that help explain it? No. 'Cause
No, but what I really, really do appreciate, Christine, is again, you're being very candid about how even you, with all of your training, working in the setting, it is difficult. And I think that's why part of the frustration for patient survivors, and as I love what you said, that for providers, you get just as frustrated and you feel that anxiety because it is complicated and it makes you just want to give up, and that works in their favor. But we're taking all these steps to educate ourselves. And like just a reminder to all of our participants, these slides will be available on our YouTube page, and we can each take the time to learn a little bit more because we can't learn all at this moment, but it's still very helpful. And knowing that our professor, you, has acknowledged that it's difficult, we're not going to feel as bad when we don't understand it either, but we're trying, and that's what advocacy is about, is just continuing to try to learn. So thank you, Christine.
Yeah, I think continuing to try to learn and understand, and then taking that knowledge and using it to A, help yourself if you're a patient or your family member's a patient, or if you work in a practice, help your practice, help educate legislators. So there's a lot we can do with some of this knowledge, even if it's not in detail and memorizing this crazy graph. So next slide, please. So I'd like to share a patient experience with everyone as an oncology pharmacist. Next slide, please. So this is a photo of myself and my father-in-law, Barry. Um, as you can see, we are wearing lovely sweaters because we have a holiday tradition of sweaters and actually wigs, which he's not wearing a wig, but I'm wearing a wig in this picture. And so every year at Christmas, we have this fun party and get dressed up, but I could not never get him to wear a wig. So unfortunately, Barry got colon cancer about, gosh, maybe 15 or so years ago. So I was actually in the pharmacy when this happened. And he came to see one of the physicians that I worked with, Dr. Patel, and got diagnosed with colon cancer. And um, Dr. Patel wrote a prescription for the drug is called Xeloda. It's generic now, or it's generic now, but we'll just use the name Xeloda for his colon cancer. And he sent it up to the pharmacy where I worked. So, okay, it's a little strange, right? Filling a medicine for your family member, but I work with my other pharmacists, so they would help. And the prescription is confusing. So it's 3 of one pill, the bigger sized pill, and 2 of the little pill in the morning, and then you take the same thing in the evening, and you take it for 2 weeks on, and then you take a break for a week, and then you start over again. And so it's not 1 pill a day for like your hypertension or your high blood pressure medicine. Or it's a complicated prescription. So they sent the prescription up, and it's also expensive. At the time it was. It's less now because it's generic, but at the time it was expensive. And so we filled the prescription and put it through the insurance, which your pharmacist is on their computer sending it to the insurance. And it needed prior authorization, which we talked about earlier. And so our team did a prior authorization, telling the insurance company why he needed the medicine for his colon cancer. It's standard, normal thing that we would give, nothing unusual. And then we found out that we couldn't fill it at our pharmacy. So, I'm literally standing there, and I can picture it now, Rose, like I'm standing there with these 2 bottles of medicine, of the 2 Xelodas, the big pill and the little pill. And I cannot give this to him because he has to send the prescription to his PBM owned pharmacy.
Oh my gosh.
And I don't know which one it was, but it was one of the 3, one of the 3 big ones I talked about earlier. And so literally I'm like standing there with his medicine, like, I can't give this to you. And I told him how to take it, right? Because it's so confusing.
Right.
So then we send the prescription to his PBM pharmacy. It's all electronic, so it's not a piece of paper anymore. And about 2 weeks later, he got it, and it comes in the mail, which is fine. But there wasn't a me standing there
Right.
to show, here's how you take your three big ones, and I'd put it in the little cup and show them what it looked like, and take it with breakfast, and here's the two little guys, and you take these, like I would literally show every single patient how to take their meds easily right there in front of me. And I tell them about the side effects and call this number if, you have nausea or whatever the side effect might be. And they would directly come to the nurse or to myself on this care team. And so that was the day I was like, wow, this really is impactful as a patient caregiver. Um, and I'll never forget that day. And because I remember how much stress it put on him and my mother-in-law to wait for the medicine. And I'm like, why would that happen when I'm literally standing here with these pills? And that really helped me understand and feel the difference of being on that side, being on the side of the patient, being the caregiver. Yes, as a pharmacist, I want my patients to have their medicine.
Right.
And so did his doctor so badly, but it was very impactful and also very scary just to be like, this is not something I can control. And I literally have these pills right here.
It's just mind-boggling. I mean, you've described it very well, but it's just so hard to understand. It just defies logic. And I think it also reflects how healthcare is right now. The PBM issue in particular is they forget that there's a real person impacted. There's a person with feelings, with hearts, with emotion, family members. They're just seeing, the paperwork part of it. And having a pharmacist, like you said, describe the way you would interact with that patient, that is so meaningful. It is so comforting. Not every patient is going to come out and say, Christine, this is so comforting, but they're feeling it. I tend to vocalize what I feel, not often, but most of the time. But I know that every patient, this happened to be a family member, but I guarantee you had that impact on so many patients because you cared and they sense it, patients sense it.
Mhm. I mean, that's it's a very rewarding career to have. So I mean, I'm very thankful to have the opportunity to work in community oncology. It's amazing. It's definitely rewarding on both sides. Next slide, please. So what can you do if you're a patient or a patient caregiver experiencing this? And I can just use my example of my father-in-law. Call your employer's health plan, talk to the benefits department and ask them if you can have the prescription filled at the pharmacy in your doctor's office. Um, Now that requires work on behalf of the patient and or the caregiver, which is not another thing you want to add to the list of stuff to do, right? It's not something that's going to be fun. You're probably going to have to be on hold for a minute. But that does sometimes work. We would have patients who would call and they would be able to get an override to fill it in our pharmacy.
Good.
And that's an immediate need and an immediate use case. Bigger than that is help us advocate on the state and federal level. So if you follow the news, and healthcare is a huge topic right now, especially focused on expense. And I think sometimes we focus on expense too much and we don't focus on how do we get patients the medicine they really need. But advocating at the state and federal level is something that COA is doing all the time. Rose and I just got back from a trip out west and visited with a couple of practices, and Arkansas just passed PBM legislation at the state level. And so there are ways that you can help advocate for yourselves, for your family members, for your patients, by just sharing your stories. I mean, me sharing the story of my father-in-law is something that story shouldn't happen, right? And if we can have legislation put into place that changes that, then that's a win. And legislation doesn't happen overnight. I couldn't have changed the law and he would have gotten his medicine, but knowing that it's continually impacting patients, I think gives us all a reason to advocate and work with Rose, your team, and the team at COA.
Thank you. And let me just lean in really quick on the federal and state advocacy. So many of you have been with us to Capitol Hill, whether you're patients, survivors, caregivers, or you work in the community oncology setting. And as Christine mentioned, over the last 4 or 5 years, we've been doing a lot more work at the state level. And we're actually going to be going to the State House in Ohio. So if you are a cancer patient or survivor that was treated in a community oncology practice, remember, community means independently owned by the physician. Please reach out to me again, because we are taking a small group up. This is specific to Ohio in this time. So you can reach out to me at roseg@coacancer.org. Or again, if we're connected on LinkedIn, you can reach out to me there and let me know if you're interested, if you know someone who might be, and then I could provide more details. Thanks, Christine.
That sounds great, Rose. Yeah, I'll be at the Ohio State House visit as well.
Perfect.
Since I live in Ohio, and some representatives from the practice I worked at will be with us. So it'll be a great opportunity to get in front of some lawmakers.
And people get to meet you. So that'd be nice.
That would be I know, so fun. That's my favorite part.
Special.
Next slide. And just sharing another just visual for you all. Federal change takes a very, very, very like 10 varies long time. And it's interesting here because you're like, well, state does too. State legislation change takes a long time too. It does, but it's less. Then there's maybe one vary. And you can just see here over the years from 2018 until now how much growth we've seen in state legislative reform. And we had a win in Arkansas. So I think continuing to push and fight is the right thing to do. It's not giving up. It's saying, we can make a change. We just have to be persistent. Next slide. For some resources on pharmacy benefit managers, you can go to the COA website, the CPAN website. There's links that'll be at the end of the presentation, but this is great information to share with you, with your patients, that shows kind of what PBMs are, what they're doing, and how we can work together to help make change.
And for those of you that have CPAN chapters in your cancer centers, several of our CPAN chapters have hosted pharmacy benefit manager events, either as a lunch and learn or as an evening event. Again, when I say multiple, we've done multiple events at these practices across the United States. And oftentimes we'll have someone like Christine as a pharmacist as a guest speaker, along with our nurse leaders, and of course, the cancer patient survivors. So if you don't have a chapter, it's probably a good idea to start one. Just reach out to me as well.
Wonderful. Next slide. Here's some references and links if you want to learn more. The last one, the real life patient impact of PBMs, the volumes 1 through 8. You may have read some of these in the past, but these are literally directly from community oncology practices, stories that our practices have shared. Some were from the practice that I worked for, talking about the issues with PBMs and patients getting their medicine. Next slide. That's it for me. Thank you all so much for having me. And thanks for celebrating Pharmacist Month with us.
Absolutely. Thank you, Christine. This was very, very educational. Thank you so much. And to all of our listeners, thank you again. Next slide, please. And I did see a question come in. If you feel comfortable and would like to reach out to me directly, I can give you an answer to that. So just remember, these are the quick ways to stay involved with advocacy is just participate in these chats, sign up for our CPAN newsletter, visit our website to learn more. We have tons of information. Share your story, follow us on social media. Next slide, please. And this is your date for our next advocacy chat, and we will let you know who our special guest will be and what our topic will be. That's going to be Wednesday, November 12th at 12 p.m. Eastern Time. Thank you all so very much and enjoy the rest of your week. Thank you again, Christine.